My story begins in 1999. I was feeling suicidal. I had such severe anxiety that I couldn't catch my breath. When I have that kind of anxiety, I have a compulsion to run. The problem is, where? I just want to run and I don't know where. The truth is, I want to run from myself. At 49, when I was finally diagnosed with chronic recurrent depression, I actually felt relieved. It helped to explain my generalized fears and anxieties, my moods, and my chronic sense of sadness. In my family, I am third generation with mental illness. I am also one of 3 million people in Canada with depression, the majority of whom are women. I came to realize that depression had been my constant companion, discoloring everything. I think it begins with what I call the 4 horsemen: woulda, shoulda, coulda, and oughta. Depression attacks the mind, the body, and the soul. My depression is dark, heavy, mind-numbing, and exhausting. I lose all feeling. No highs, no lows, just indifference. It has left me lifeless, curled up in a ball, in my bed. I'm Diane Biederman. Welcome to the many voices of mental illness.
Manic depression is searching my soul.
No one is immune to mental illness. No one. 1 in 5 Canadians has been diagnosed with a mental illness. 1 in 5. That's more than 6 million Canadians. And that number doesn't include the mothers and fathers, the sisters and brothers, and all the children who are also affected. Mental illness knows no boundaries. You can be homeless with a mental illness or live in a mansion. Over the next 6 weeks, I'll be taking you on a magical mystery tour of mental illness. You'll hear a common theme running through the many voices, from the voice of a psychiatrist to the voice of a mother whose son attempted suicide. That theme, mental illness, is no different than any other chronic illness, from heart disease to diabetes, HIV/AIDS to cancer. And the family and friends who care for those with mental illness, they need the same compassion and support that we give families who live with chronic physical illness and disabilities. You may see yourself or someone you know in the voices that you hear, and if you do, you won't be afraid. You will seek the help that you need. This series explores the many treatments available for mental illness, the legal rights of patients and families, the connection between mental illness and addiction, and the effect of mental illness on families. It is my hope that after this series, you will come to see that those of us with mental illness are just like you. I asked Dr. David Koczerginski, Chief of Psychiatry at William Osler Health System, to define mental illness.
Great question, tough question, because it obviously exists along, mental health exists along a spectrum or a continuum. It's very important to distinguish, what is the normal range of expected human emotions in response to stresses, and when does that become syndromal or an illness, and when does that require treatment either by a physician or by another mental health professional. So we tend to think of these things as crossing over into illness when they are persistent, so not just a day, not just 2 days, but go on for weeks or oftentimes months. When they're pervasive, so that they're there most of the time, most of the day, every day, and when they cause impairment. And that's really a key criteria. So people can experience all kinds of emotional symptoms, but they may be still functioning well and still able to do their jobs and still enjoy activities and still participate in relationships, and typically those are not the people that end up coming for treatment. So Mental illness usually results in some degree of functional impairment to the individual in one of the major spheres of their life, either the way that they think, the way that they feel, their ability to function productively, to work, their ability to function productively in relationships.
The GP has said I have depression, but what kind of questions would you ask me to find out exactly what my mental health is?
Well, typically I would ask somebody to let me know what their understanding is of why they are here to see me. And sometimes the answer is really straightforward, that I've been feeling sad or depressed. And sometimes people's understanding of why they're coming to see you is completely different from what the family physician may have put on a referral letter. Sometimes people may say that they're here because their spouse wanted them to be here or their parent wanted them to be here. And then we need to dig a little bit deeper into that. So I will typically ask people to put in their own words why they understand what is it that brought them to their family physician, and what is it that brings them to see me.
I met a woman whose teenage son had called her into his room. "Mom," he said, "I need help." He was lying on his bed, curled up. "There's something wrong. I can't stop the crazy thoughts in my head and they're scaring me." She took him to the family doctor, who diagnosed an acute phase of a mental illness, prescribed drugs to calm his brain, and arranged for an appointment with a psychiatrist. So the two went together to the psychiatrist's office, and she waited while he saw the doctor. Her son was over the age of majority, so the psychiatrist needed his permission to tell his mother what was going on. Her son came out of the office, and while walking toward her, he mouthed the words, "I'm not coming back." She looked over his shoulder at the doctor and said they'd be back for the next appointment. Her son had been frightened by the questions the doctor had asked him, but he needed help.
To bring me back to life.
I asked Dr. Koczerginski what questions he asks at a first appointment.
So if people identify that they are here because they've not been feeling well, or they've been feeling sad, or they've been feeling fatigued or lethargic, or any one of the many symptoms that may suggest that there might be depression, then typically we'll go through a little bit of a symptom checklist. So we'll ask people, have you been feeling sad? Have you been losing interest in activities? Is there a loss of pleasure? What kind of things did you used to enjoy doing? And do you still do them, and do they still give you pleasure? And then there are other associated symptoms of depression that we commonly see, things like disturbances of sleep, disturbances of appetite, concentration, energy, sometimes physical pain, oftentimes anxiety. So there's a host of symptoms that we'll kind of go through. And then I will typically ask people to try to put into their own words, if they can quantify just how depressed they've been. And some people can do that, and some people need some hints. So, for example, have you been feeling emotional? Have you been crying? How often? Do you feel like that every day? And then, of course, another measure of severity that we commonly see with depression are thoughts of death, or thoughts of hopelessness, thoughts that they may no longer wish to be around anymore. And depending on how those questions are answered, then that will obviously proceed to questions about whether people have had thoughts that may put their own risk or safety or integrity in danger, thoughts that they may hurt themselves, harm themselves, or thoughts that they may have of ending their lives.
When you see someone, how do you establish how long it will take for you to be with them, how long their therapy will take? How do you assess that?
It varies greatly, obviously, from individual to individual. Typically a first assessment, a first appointment will usually be anywhere from 45 minutes to an hour to get to know someone. And then treatments in psychiatry, are, I guess broadly speaking, in the broadest of terms, fall into two categories. So there's biological treatments, which are most commonly medications, not just medications, but commonly medications. And there are psychological treatments, which is usually what's referred to as talk therapy of some sort. And depending upon individuals' preference, some people like the idea of taking a medication and are not keen on speaking, and other people are the reverse. They fear and loathe medications and prefer to speak. So depending upon patient's preference, and of course depending upon the way they're presenting and the recommendations that I give, most people will receive one, the other, but more commonly some combination of both.
I've read that the earlier you seek help when with the onset of a mental illness, the better the prognosis. At the same time, people still have this fear of being labeled as having a mental illness. What is it that you think keeps patients from coming and keeps friends and family still fearful of finding out that a loved one has a mental illness?
Yeah, those are great questions. Ultimately, there are so many factors. The largest one, I guess, could be considered under the heading of stigma. Unfortunately, people think of mental illnesses, sadly, unfortunately, tragically, as being different than suffering from a physical illness. So, people tend to not feel embarrassed about going to a physician for their diabetes, for their hypertension, for their kidney failure or liver problems, whereas it feels differently going for a mental illness. It shouldn't be. Mental illnesses are complex animals, but we know that they have biological, genetic vulnerabilities and underpinnings. We know that they respond, for the most part, they do respond to treatment, and I would argue that that the success of psychiatric care and success of psychiatric treatment rivals that of other areas of medicine in a very positive way. Most of our patients do actually do well. We have good treatments, and it is the unfortunate stigma that prevents many people from coming. I do think it's changing. I've been doing what I do for over 20 years now, and I've seen changes in the last couple of decades. I think we still have a long way to go, but I think that there is more acceptance now than there was 20 years ago.
Mental illness knows no boundaries: race, color, creed, religion, age, neighborhood. Does it present itself differently amongst different cultures? Are there different triggers? Because we are a multicultural society. When I'm talking to you about the triggers of mental illness, are they different in different cultures? Or when we talk about all these things, would anyone listening from any culture be able to recognize themselves in the discussions we've just had?
Sure, people are people right across the world. So I fully agree that age, gender, culture, race, socioeconomic status, none of it is fully protective for mental illness. There are some cultures where mental illness is more heavily stigmatized. So to speak of depression may not be acceptable. So the presentation absolutely may be different. People may present with far more physical aches and pains, and anxiety may manifest itself through a whole host of physical symptoms, as well as can depression. That may be pseudonyms for depression, and again, I believe family physicians are becoming far more sophisticated at recognizing this. That there's different types of pain, and emotional pain can manifest itself as physical pain. And of course there are some gender differences. So I think that men in some ways do worse. Men are more reluctant to see family physicians and may view it as a greater weakness to identify depression. Men also tend not to share with each other as much, so they may not benefit from the ability to confide in peers and friendships. And men may be a little bit more vulnerable towards expressing their depression in either in aggressive terms, going out and getting in arguments or fights or irritability, or in expressing their depression through self-medicating with alcohol. And we see much under-recognized depression in our addiction treatment programs across the province.
I'm Diane Biederman, and you are listening to the many voices of mental illness.
Manic depression is searching my soul.
30 years ago, when I was raising my own young family, I got a call from my mom. Come quickly, Dad isn't well. When I got to the house, my dad was in the family room, sitting in his favorite chair, surrounded by his dearest friends. It all looked normal. Listening to the conversation, I knew that my dad was in the middle of a mental health crisis. My dad was bipolar. He needed to be in a psychiatric unit. Recently, I met a young man, Peter, who, like many others to whom I spoke, wants his story told, but shame or guilt seem to hold them back from identifying themselves or their families or telling their own story. So I carry their voices with me. Peter had known for a long time that his father was mentally ill. Living with him is difficult. He has highs when he is full of energy, ready to clean the garage, repair the roof, fix the toilet. He's full of life and full of plans, and he is so happy. He's flying. I know that feeling, the flying part. But as his son tells me, the high goes crash down into the darkness. All the energy is gone. I know that feeling too.
A winter's day in a deep and dark December, I am alone, gazing from my window.
Sometimes people with mental illness enter the system through the emergency unit of their local hospital. That can be intimidating. So let's go through an emergency room together. Ajimol Mohan is a healthcare worker at Headwaters Health Care Centre in Orangeville, Ontario.
Even though my designation here is mental health transitional care worker, it's basically what I do is helping patients through mental health crisis. So if there is no immediate medical issues which needs to be addressed in ER, when the patient comes in, they let me know that there is a patient, and they will keep the patient in a quiet room or any area. If the quiet room is busy, they'll find some other place in ER itself, and they will tell me that there's a patient waiting for me.
So people that are in a crisis and have been brought in probably either by a parent or a child, they won't have to wait in the ER with everyone else?
No. If I'm busy with another patient, I usually come and see the patient and say, hi, I'm so-and-so, but I'm seeing somebody right now, but I would be seeing you within half an hour or 1 hour or so. We don't have much waiting period with regard to mental health crisis because, there is a waiting period if they have any medical reason to be seen by the doctor. In that case, for example, if the patient is coming with an overdose and the patient needs to be medically cleared before I see the patient, so then he or she needs to be seen by the ER physician who will do the appropriate testing and whatever is necessary before I see. And or in the case of intoxication, we would wait until the alcohol level is pretty low for me to have an interview and make a proper assessment. So then there is a waiting period to be medically cleared.
Peter spent about an hour listening to his father's stories. He said that this is not unusual, but here they were in this small, quiet room, all alone, no distractions, except for the sound of gurneys up and down the hallways. An hour can feel like a lifetime. Peter told me that it was exhausting, keeping up with the stories, worrying about his dad. Peter remembers times growing up where his dad was like this, but no mention of mental illness was made at home. Peter told me that this was his family. He thought of it as normal. Well, it was for him. Once you've decided that someone is ill enough that they need to be admitted to a hospital, what's the procedure?
Well, what first happens is I interview the patient and the family and discuss the assessment and the recommendations and referrals with the doctor. So even though the patient hasn't seen the doctor first, he or she will be seeing the doctor later after I make the assessment, and I discuss the plan depending on the situation. For example, if the patient is not in a situation where he can go home safely, in that case, we would discuss that with the patient and the family, and we would say that we think that my recommendation is that the patient stays in the hospital for now, and we have to come up with a plan. And the plan would be first again medical clearance and transfer the patient to a facility, a psychiatric facility where the patient can be seen by a psychiatrist and a team of psychiatric nurses and social workers. I know that earlier there was a lot of waiting period, and sometimes patients have waited for days to get a bed, but that's not the case anymore.
They agreed that his dad needed to be admitted, but this hospital doesn't have a psychiatric unit. Peter's dad had to be transferred. Transfers from Headwaters are fairly quick, from a few hours to at most 2 days.
Nobody walks out of this hospital without a follow-up plan. And the follow-up plans are, if the patient is already seeing somebody in the community, then they will go back. I call that with the consent. I call the counselor or the therapist, whoever, and then discuss the plan. And if the patient does not have a follow-up right away, they usually discuss with us and get a follow-up session right away in next 2 days. That's a mandate in next 2 days if the patient is so bad. And if I cannot find a place for a patient to go or see somebody in the community, I do follow up a few sessions for that patient to stabilize until they are able to see somebody in the community.
Peter's dad was taken to William Osler Health System. The days in the hospital gave the doctors time to find medication to help him. It's frustrating for Peter, more so than his dad. Each day is a surprise. What mood will his dad be in today? Peter believes it's his responsibility to help his dad feel good, keep him occupied, make him happy, and he tells me that his feelings go up and down like his dad's. It's as if he has lost himself in his father. There are days when his dad calls constantly, sharing every little detail, and there are days when Peter doesn't want to answer, and he feels guilty and shameful for feeling that way. Today, there are many support programs for people like Peter, and we will talk about them during the series. Today, we heard from Dr. David Koczerginski and Ajimol Mohan. You can access information about mental health care through the Canadian Mental Health Association, cmha.ca. For more information in Ontario about access to mental health care, contact Connex Ontario at connexontario.ca. Help is available 24 hours a day in more than 140 languages. This is Diane Biederman. I'm off to Pilates. Thank you for joining me for the many voices of mental illness.